Sarah and Vidya presenting today. And since I saw you were here, Sarah, how about if you lead us off with the patina data, which is perhaps arguably the most exciting thing from the meeting.
Absolutely. Give me a second to pull this up. Okay, don't mean to start in the middle there. Um, all right. Um, let me do slide mode. Here we go. Okay. So the patina trial is a clinical trial, phase 3, looking to evaluate the efficacy and safety of palbo given with maintenance anti-HER2 therapy, HP, with endocrine therapy in patients with ER positive, HER2 positive metastatic breast cancer. Um, so we know that about 20% of breast cancers have overexpression of HER2, and roughly half to two-thirds have co-expression of the hormone receptors. The CDK4/6 pathway has actually been shown to be implicated in the maintenance of survival of HER2 positive breast cancers. We know that there are resistance mechanisms invoked by this pathway to HER2 targeted therapy. So there's ample preclinical rationale to combine CDK4/6 inhibitors with HER2 targeted therapy and endocrine therapy. So this is a nice graphic that Sham Goel put together several years ago, 10 years ago almost, in his very well known Cancer Cell paper, where he depicted the role of HER2 and CDK4/6 pathways converging together at the TSC2 tumor suppressor protein. So when CDK4/6 and HER2 inhibitors are combined, this potently suppresses the retinoblastoma phosphorylation and mTORC1 activity, which enhances anti-proliferative effects in tumor cells. And actually, data from a preclinical standpoint has been building for 10 years. Back in 2015, Rich Finn showed the activity of palbociclib in HER2-positive breast cancer. Similarly, data has been shown by Neil O'Brien for abemaciclib in HER2-positive and by others for ribociclib in HER2-positive. And there have been other trials looking at CDK4/6 inhibitors in HER2-positive, ER-positive breast cancer. Most notably was the Monarch study that Sarah Tolaney led, showing that abemaciclib plus trastuzumab and fulvestrant had a better progression-free survival and objective response rate compared to trastuzumab and chemo in ER-positive, HER2-positive breast cancer. But it was a phase 2 study and didn't meet survival benefits and was never pursued as a regulatory pathway, so is not approved. So this is a phase 3 trial looking at this question here, and this is the design of the study. Patients with ER-positive, HER2-positive metastatic breast cancer who've had no therapy other than induction chemo were allowed on. So patients prior to being screened for the study had to get 6 to 8 cycles of treatment with trastuzumab, with or without pertuzumab, and the majority did get pertuzumab, and either taxane or vinorelbine. In Europe, vinorelbine's used in many patients as a replacement for taxane in induction therapy in the frontline setting. The regimen was done for 6 to 8 cycles, and then those patients who were able to achieve complete response, partial response, or stable disease, so anything short of progression of disease, were allowed to be screened and enrolled in this study. So just keep in mind the worst behaving disease, those patients with outright progression during that induction phase were not eligible for this study. And that's important to note as you look at the data that I show you with progression-free survival. So patients are randomized 1-to-1 in an open label fashion to receive palbo with HP plus endocrine therapy or HP plus endocrine therapy. Again, the majority of patients receive pertuzumab, although it wasn't required. And so there's a 90% power. The significance level was set at 0.025, and the final analysis was planned out of 200 after 269 events for investigator-assessed progression-free survival. They enrolled between 2017 and 2021, 518 patients. So here is the consort diagram showing how the breakdown occurred. Here is the patient characteristics, fairly well balanced. And the median number of induction cycles was just about 6, which I think matches our standard practice for induction chemo and first-line HER2-positive disease. As you can see, almost all patients received pertuzumab, so this does reflect the type of treatment we give here in the US. The endocrine therapy was the vast majority of patients utilized an aromatase inhibitor, and the best response to induction therapy was around 70%, which I think is what we see with the chemo HP induction regimen as a whole and is fairly representative of what we saw in Cleopatra. And here is the investigator-assessed progression-free survival, very nice, like 15-month improvement in the median progression-free survival. The statistical significance was met based on their pre-specified threshold, hazard ratio 0.74. What I found to be really notable is that median PFS of 29 months in the control arm, which if you remember from Cleopatra, in the frontline setting, the median PFS was about 18 months, just under 19 months. So this is really good for the control arm, but we can't compare those two studies because remember, Cleopatra patients were enrolled and randomized at the initiation of induction chemotherapy. So those patients with resistant disease who progressed during those first 6 cycles were counted in Cleopatra and were not enrolled in this study. Moreover, this is a patient population that is exclusively hormone receptor positive, whereas Cleopatra had hormone receptor negative patients enrolled, so they may do better. All of that said, this difference in outcome by adding palbociclib was notable and I think does meet the mark for being historic data. Here's a forest plot showing that based on these subgroups, you still see benefits with the use of palbociclib regardless of use of prior anti-HER2 therapy, regardless of what type of response they had to induction. And looking at objective response rate, nothing really huge here, but you do see a trend or a nice small improvement in the objective response rate and clinical benefit rate by adding palbociclib. The second interim analysis for survival is shown here. It's trending in the right direction, but didn't meet statistical significance. And then the adverse events, nothing surprising here. Of course, with palbociclib, you're seeing about 3/4 of patients having grade 3/4 neutropenia, nothing that we don't handle normally here. And we see lots of patients on palbociclib for years with metastatic disease, higher rates of fatigue and diarrhea as well as stomatitis. But again, nothing that is out of what we're normally seeing with palbociclib. So this does reinforce the rationale for overcoming resistance to anti-HER2 therapy and endocrine therapy by adding a CDK4/6 inhibitor to the maintenance setting after induction chemo. We saw about a 15-month improvement in median PFS by adding palbo to anti-HER2 therapy and endocrine therapy. There was increased toxicity owing to the cytopenias, fatigue, diarrhea. But it is similar to the side effect profile that we see with ER-positive, HER2-negative disease. I actually was able to do the discussion for this, and in my own opinion here, and I'll stop sharing now, let somebody else get ready. I think these data were practice changing. We don't have an FDA approval for this combination. I can tell you in the metastatic, very heavily pretreated setting, when I have a patient on 7th, 8th, or 9th therapy and they have ER-positive, HER2-positive breast cancer, in the past 5 years, I've used palbo and abema combined with HER2-targeted therapy. I would imagine some of you have done that as well. When you have a healthy patient, you're grabbing for something that would be fairly well tolerated. I think this is something to discuss with patients. I don't know that the approval is going to be problematic since it's an oral drug and a different way of gaining approval. Certainly having it listed in our NCCN guidelines or having a formal approval by the FDA would be really nice and would sort of provide backup for that strategy. But I think these are very compelling data. I am looking for the overall survival outcome data as well as patient-reported outcomes I think are going to be important, and publication. So maybe I won't be super excited to actually roll this out until we've seen the peer-reviewed publication, because this was thrown together in a week. They had a week to put together this presentation. So maybe having a few more eyes on it before rolling it out would be reasonable, but interested in what other people's thoughts are. Thanks for letting me present.
I've certainly done it, Sarah, but and I've sort of done it by pretending that the right hand and left hand aren't paying attention to each other, and I get ER positive approval for one drug and HER2 positive approval for the other intravenous drug. So it's gettable and doable, and I have seen really nice responses, and we're very, very interested in this. But the real critical thing is, what would it take to get this NCCN approved? I mean, is Patina enough as a peer-reviewed paper?
Yeah, I mean, I bet you it will. I think they meet in April, if I recall, when I was on the panel, but around that time is, I'm sure this is going to be discussed by the committee that is looking at HER2 positive metastatic breast cancer. And just because we have so much safety data about palbo, and this is actually now adding to cumulative evidence from patina and not patina, from DETECT-5 and Monarcher and the Soltis study. It's not just one study, so I think there's ample safety data to get them to move, but we'll have to wait and see.
Great. It looks like Dr. Hunter has a question.
Hi, I was just curious about your thoughts. If this were to be approved, I'm sure we all have a number of patients who are already on maintenance therapy. Would you think of adding this to what they're on, or waiting until they progress and then switching over to maybe a different endocrine backbone and a CDK4/6 inhibitor?
It's a great question, Tasha, because there are some patients who are on maintenance HP for 5 or 10 years. And it's kind of like when Palbo came out and we had all these patients in the front line with ER positive metastatic breast cancer. Is like, do we add Palbo to the AI that they've been on for 6 years? I think most of us didn't change practice for patients who were doing well, who'd been on it for over a year. This is going to be the art of medicine. In terms of data supporting its use as a second or third line strategy, it's not as strong, right? This was clearly just front line, but I do feel it belongs somewhere in the armamentarium. I don't think I'd use it before TDXD since we have survival data now, or maybe even tucatinib, but there is a lot of room for other regimens in patients in the later line setting. But I don't know if other people have other thoughts on how to use these data.
I guess I think I'd love to see the manuscript come out and feel a little more comfortable pushing for it once we have a peer-reviewed manuscript. And I would imagine the same, that NCCN's probably a little more flexible in terms of looking at the data to get a compendium listing for it for this indication. I do think we always have to keep in mind there is the financial cost associated in the checks and the things, which is going to add a little bit of inconvenience to patients who might otherwise be coming in just every 3 months or something, aside from their HER2 directed therapy. So I guess the other question will be is if patients want to do something different other than Palbo, or if, Ribo is going to try to sneak in on that same sort of indication. But certainly exciting to see another option that sort of makes sense based on the science and what we expected. So great. Other questions? All right. Well, thank you. Sorry, I joined a little late from clinic. I think the plan was to ask Dr. Reed Perino to take over next. Hand the mic.
Okay, let me share. Little either. Can you guys see this? Okay. Yes. Okay. All right. So I was going to talk about some new data shared about Destiny Breast 06, and then sort of touch a little bit on the HER2 ultra low piece of this in light of the new FDA approval, and then the Olympia 10-year interim analysis. So just as a reminder, Destiny Breast 06 brought on this new designation of HER2 ultra low that was defined as IHC 0 with membrane staining. The trial enrolled 866 patients that had metastatic HR positive, HER2 low, or HER2 ultra low breast cancer. That was the ultra low part was 18% of patients, and they had greater than or equal to 2 lines of endocrine therapy for metastatic disease, or 1 with either disease recurrence within 24 months of initiating adjuvant endocrine therapy, or disease progression within 6 months of initiating first-line endocrine therapy with CDK4/6 inhibitor for metastatic disease, but no prior chemotherapy for metastatic disease. They were randomized 1-to-1 to trastuzumab deruxtecan or chemotherapy of physician's choice. That could have been capecitabine, paclitaxel, or nab-paclitaxel. This population had a median age of 58 years. They were 31% with de novo metastatic disease, 67% had liver metastases, and 85% had visceral metastases. The primary endpoint was median PFS in the HER2 low cohort, and this showed a difference of 13.2 versus 8.1 months and was statistically significant. Secondary endpoints included median PFS in the intention to treat population, so that's low and ultra low, and that was essentially identical, but remember that the ultra low was a minority of these patients, so it'd have to be quite different to move that. And then median overall survival in the HER2 low and intention to treat populations were immature. Adverse events showed no new safety signals. There was ILD in 11.3% of patients. 0.7% of these were grade 5. So here's the sort of concentrating on the ultra low for a minute. Here's the progression-free survival data. It shows that there is a difference. The numbers are very low, and so sort of accordingly, they're not statistically significant. But when you look at other markers of efficacy, it's really comparable to HER2 low disease. So on the left here is the HER2 low population, on the right is the HER2 ultra low, and then intention to treat in the middle. And so by objective response rate, median duration of response, and clinical benefit and disease control rates, it's really, for trastuzumab deruxtecan, it's quite consistent across the field. There are some difference in the chemotherapy response, though. So updates that we got at San Antonio. So there was an exploratory post hoc analysis looking at the benefit in patients by response to endocrine therapy. And so this was shown in a couple of ways. The first one was PFS by time to progression on first-line endocrine therapy and CDK4/6 inhibitor. This included about 66% of the population. So you can see if you had progression within 6 months of your first line of therapy, there was a 7.5-month difference in median PFS. And then there's 6 to 12 months and then greater than 12 months. And there's sort of a trend towards the longer response you had on your first line of therapy, the smaller the difference was between the TDXD and chemotherapy arm. And then this was presented in a different way by showing that by the type of endocrine resistance, so primary endocrine resistance being defined as progressive disease within 6 months of first-line endocrine therapy for metastatic disease, or relapse in less than or equal to 2 years of starting adjuvant endocrine therapy, and this was 31% of the population, versus secondary endocrine resistance, which is progressive disease in greater than 6 months on first-line endocrine therapy for metastatic disease, or relapse after 2 years of starting adjuvant endocrine therapy, or less than or equal to 12 months of completing adjuvant endocrine therapy. But you can see that the TDXD responses in both of these cohorts are fairly similar, but the difference, to me, most notable is actually in the chemotherapy response being better in the secondary endocrine resistance group. Then they showed PFS2 data. So this is from time from randomization to second progression or death. And so you can see that in the whole intention to treat population, the median PFS2 is significant. And actually the hazard ratio here is identical to median PFS1. But interestingly, when they show it broken down by, again, these time to progression groups, so less than 6 months on first line, 6 to 12 months, greater than 12 months, there's sort of actually a reverse trend to what was seen with PFS1. So there's a smaller difference now between TDXD and chemotherapy, and a larger difference with more of a response. And then finally, they showed PFS by metastatic disease burden. And I'm sure this is not a surprise to anyone, but you do worse when you have more sites of disease. This is true for both chemotherapy and TDXD. And then some data about specifically liver mets, visceral disease, and baseline tumor size greater than or less than the median. And again, very similar numbers throughout, comparing TDXD versus chemotherapy, and sort of the difference between the two is consistent, with the outlier here of if you don't have visceral disease, you actually get a pretty marked benefit with TDXD. This is impressive data, essentially a doubling. So for HER2 ultra low, so now there's an FDA approval for HER2 ultra low as of earlier this week. So what do we do about this? I think there's some things that it brings up. Our pathologists, at least leading up to this approval, have not been commenting on IHC 0 with membrane staining. There are no ASCO-CAP guidelines regarding HER2 ultra low staining and designation and what that means. There's significant interpathologist variation. This has been shown many times. There's significant intra-sample variation. So from the same slide block, different day with different reagents, and intra-specimen variation, so different area of the same tumor. And so I guess the question is, do these data mean that everyone should be eligible for the drug? Or is there a true negative subset of patients who will or would not benefit? And then I think it's inevitable that until there's standardized practice, there's going to be differences in treatment and care that is offered, depending on where you are and who's taking care of you. I don't know, the other thing I was going to present was Olympia. Should I pause to discuss this or sort of keep going?
I don't know if anyone has questions or thoughts. I mean, it seems as though, and I guess I heard Mark Pegram say this yet again, but it sounds like when the original HER2 assay, we all know the problems with the IHC assay. It was not detected to look at these ultra low levels, but I think you had to get fresh frozen specimens to be able to identify. And even in those cases, I think there was always some low level of HER2 expression. So again, it kind of feels like it's almost for everyone at this point.
I agree totally. And that comes from the Mike Press paper back in the 90s showing that as soon as you fix them, you lose that antigen. And it's, of course, antibody dependent as well. So it all just seems a bit silly that we're using IHC to quantify and identify patients who are eligible for TDXD. But I think maybe even a bigger question that's coming up now is, how do we select among these ADCs for hormone receptor positive disease? Because we had Dato-DXd approved this week, the same indication. We have sacituzumab. I guess the difference with TDXd is it can be used as the first line of chemotherapy for our patients. But I'm grappling with that because I think, I'm not impressed with the sequencing data, whatever that is, which is very small. So I think our best shot on goal is with the first ADC we use.
Agreed. And I think there's, yeah, some data to support that your response is better with whichever you pick first, and it's going to get worse beyond that. So, and Mark Kilgore's putting in the comment in the chat, so thank you. Appreciate that. And Mark, we've appreciated pathology working with us when we had the 1+ cili indication, and that has been super helpful. So I don't think we're going to go back and ask you to reread for ultra low. At
Yeah,
least I wasn't planning on it.
Yeah, we're happy to help. Thanks. Yeah. And I mean, people have talked about it's not what the assay was designed for. So people often say that, the assay was designed to find an elephant, and now we're trying to use it to find a mouse.
I guess it's a good point just to bring up quickly that we are going to be opening the Quantify Her study that video will be leading through TBCRC, looking at a truly more quantitative assay with Dave Ram's lab. And I think it'll be still relevant to try to maybe help us understand a little bit better about when TDXD might be the best choice among the different ADCs. And I'm hopeful eventually we'll be able to make smarter choices. But
Yeah, that'd be great. It would be awesome to work with David. We know David Rem pretty well, so that would be
yeah.
that'd be a great collaboration.
Yeah. Vidya is on tap to be our site PI for that. And I think we're just waiting with TBCRC and team to get protocol and documents. So thanks, Darian. Keep going.
Okay, I will push forward. And I was going to talk about Olympia and the 10-year interim analysis updates that were presented at San Antonio. So I wasn't going to talk a whole lot about the basics of the trial. I think most people know, but it evaluated 1 year of adjuvant olaparib versus placebo in 1,836 patients with germline BRCA1 or BRCA2, or there was a small population who had both mutated HER2 non-amplified high-risk early-stage breast cancer. And so how was high risk defined? For triple negative, it was if you had neoadjuvant chemo, you didn't have a PATH-CR. If you had adjuvant chemo, it was PT2 or higher or PN1 or higher. And if you had hormone receptor positive disease, which I just note was actually 1% or higher, so not 10, which is sometimes used. If neoadjuvant chemo was used, then no PATH-CR, and then you had to have this score on the CPS plus EG, which is a marker of sort of residual cancer burden, of greater than or equal to 3. And if adjuvant chemo, you had to have 4 or more positive lymph nodes. The patient population was 42 to 43 years old. It was 70% BRCA1 mutated, 60% premenopausal, 75% underwent mastectomy as their primary surgery. 80% was triple negative disease, and it was split about evenly for neoadjuvant and adjuvant chemotherapy. The primary endpoint was invasive disease-free survival. Secondary endpoints were distant disease-free survival, overall survival, BRCA1 and 2 associated cancers, symptom health-related quality of life, and safety. And so at the first pre-specified interim analysis, they showed statistically significant improvement in IDFS and DDFS. In the second pre-specified interim analysis, they showed statistically significant improvement in OS. And so in this third analysis, which was 10 years from first patient in, with a median follow-up of 6.1 years and a maximum of 9.6, the analysis was descriptive, given that all of their alpha had been, quote unquote, spent. So looking at the IDFS update and what the first IDFS events were, you can see that essentially pretty stable to slightly better difference in IDFS with olaparib compared to placebo. The first event continues to be most commonly distant recurrence. And across both arms, it's about a third or so CNS versus extra CNS, low levels of regional and local recurrence and contralateral, second non-breast primaries, and then low numbers of deaths without prior IDFS event. Looking at the 10-year DDFS and overall survival, again, stable DDFS difference of 7.8%. Overall survival is stable to slightly increased at this analysis from 3.3% difference to 4.4%. Looking at the cause of death, by far the most common cause of death is breast cancer recurrence in both arms, with small numbers of other causes of death from various things, some of which we will touch on as events of interest, including other BCRA associated cancers and AML, MDS. The 10-year safety events of special interest, you can see that there's really not a difference, a significant difference between the arms in MDS AML or pneumonitis, which was another concern with PARP inhibitors. And looking at new primary malignancies associated with BRCA mutations, so breast, ovarian, fallopian tube, pancreas, and others, there are actually fewer events on the olaparib arm, which is perhaps not so surprising. And then looking specifically at new breast and ovarian cancers, and then on steady pregnancies. So up here, this is a little bit confusing to wrap your head around, but so they broke it down by people that had undergone mastectomies after randomization. And sort of the way I could think about it easiest is looking at what percentage of those who underwent mastectomy after randomization were then found to have non-invasive or invasive disease, and it's numerically a little bit higher in the placebo arm. And then same for BSO, again, after randomization, so presumably on exposure to drug, the percentage found to have a new primary ovarian or fallopian tube cancer, again, numerically increased in the placebo arm. And then reassuringly, there are an equal number of pregnancies across the arms. And so conclusions, continued stable benefit with 1 year of olaparib in this subset of patients. The most common IDFS event is distant recurrence, and the most common cause of death is breast cancer recurrence. There are no new safety event signals, including the risk of MDS, AML appears to be equivalent across the arms, and pneumonitis as well. And there are fewer new primary malignancies in the treatment arm and equal rates of pregnancy between the treatment and placebo. I was not able to find data regarding ovarian function suppression during treatment from what I could find, which I thought would be interesting, but was not able to find that data. That was my whirlwind tour of that.
Thanks, Darian. Any more questions? Great to see this data, and particularly with the long-term safety as well. So I think the plan was for Dr. Meyer to go next. I think she's got several updates for us. So thanks. Hand the podium to Vidya.
Okay. Hopefully you can see my slides.
Look great.
Okay, great. So there we go. Okay, so I was hoping to cover 3 abstracts, time permitting, including EMBER-3, the PADMA study, and MARGO. So the first abstract I wanted to cover was the EMBER-3 trial. So this was a trial of imlunestrant, which is a novel oral selective estrogen receptor degrader, oral SERD, as monotherapy and in combination with abemaciclib for patients with ER-positive, HER2-negative metastatic breast cancer who have been pretreated with endocrine therapy. So as background, we know that endocrine therapy in combination with CDK4/6 inhibitors are current first-line treatment for metastatic patients who are ER-positive, HER2-negative. We also know that after progression on CDK4/6 inhibitor and endocrine therapy, continued suppression of the estrogen receptor and CDK4/6 pathway are still important in terms of improving our outcomes for patients. And we also have data, including data from the post-MONARCH trial, that shows that there's continued benefit of abemaciclib, even for patients who have been pretreated with CDK4/6 inhibitors. We also have fulvestrant, which is currently the only oral SERD that's approved both as monotherapy and in combination with other therapies for subsequent lines of treatment in this patient population. But we do know that the efficacy is limited for patients who have ESR1 mutations. And I think many of us have experience with difficulties in terms of administration for patients based on the fact that it is an intramuscular injection. We also saw there's the data that was presented as the discussion after this abstract about the dosing of fulvestrant in terms of its struggle with reaching Cmax concentration. And then we also have we have elacestrant now, which is currently the only oral SERD that's approved in the setting as a monotherapy for patients with an ESR1 mutation. And when comparing the oral SERDs to fulvestrant, we see that the oral SERDs actually are able to achieve more of this consistent target biologic dose. And so that brings us to imlunestrant, which is now a next generation oral SERD that also has evidence of penetration of the blood-brain barrier as well. And so in terms of study design, this included patients who had ER-positive, HER2-negative metastatic breast cancer. In terms of prior therapies, there was a significant portion of the patient population that had adjuvant treatment who had recurred within 12 months of completion of adjuvant AI plus or minus CDK4/6 inhibitor, as well as people who had prior first-line treatment in the metastatic setting with AI and CDK4/6. They stratified patients based on their prior CDK4/6 therapies as well as visceral metastasis. They randomized patients into 3 groups: imlunestrant alone, standard of care, which was just fulvestrant or exemestane, and then combination imlunestrant with abemaciclib. And then for primary endpoints, they looked at progression-free survival between the different groups based on their ESR1 mutation status. And then secondary endpoints also included overall survival. So who exactly were included? I think the breakdown in terms of this patient population is important when we think about the results, because a third of patients had adjuvant-only treatment, and only 2/3 of the patients had first-line prior treatment for metastatic breast cancer. And of that, 60% had prior CDK4/6 treatment, and nearly all received palbociclib or ribociclib. None had prior PIK3CA or AKT targeted treatments. And then when we think about breakdown in terms of mutation status, 30 to 40% had ESR1 mutations, and about 40% had PIK3CA mutation. So the first primary endpoint of the study was progression-free survival, looking at imlunestrant monotherapy versus just standard of care endocrine therapy for patients with ESR1 mutation. So we do see there is a PFS benefit, 5.5 versus 3.8 months. That was statistically significant and led to 38% reduction of risk of progression for patients who had ESR1 mutation. When we look at the breakdown of this PFS based on subgroups, we see that this benefit holds regardless of presence of visceral metastases, if they've had prior CDK4/6 inhibitor, and regardless if they have a PIK3CA mutation. When they looked at imlunestrant for all comers, so regardless of their ESR1 mutation, we see that there is no benefit. Really, here's the PFS of 5.6 versus 5.5 months, so no difference between these two for those who did not have ESR1 mutation. So then The next PFS endpoint was for imlunestrant in combination with abemaciclib versus imlunestrant alone. And this was in all patients, regardless of ESR1. And so we see that when we combine it with CDK4/6 inhibitor, there's a longer PFS benefit, 9.4 versus 5.5 months, which was statistically significant. And then looking at the breakdown in terms of subgroups, we see here what's interesting is that the benefit is more pronounced if they've had prior CDK4/6 inhibitor, but then when you see if they have not, actually the confidence interval there crosses 1. We saw that there was benefit regardless of ESR1 mutation as well as if PIK3CA mutation. So then they broke it down. They did a subgroup analysis based on presence of ESR1 mutation in the combination, looking at the combination of CDK4/6, and we see that for those with ESR1 mutations, the progression-free survival is even prolonged at 11.1 months, and those without ESR1 mutation still have a benefit, 9.1 months versus 5.5 for imlunestrant alone, so this is basically showing that the combination continues to have benefit regardless of their ESR1 mutation presence. And then they also looked at a subgroup analysis for prior CDK4/6 inhibitor. So in the combination arm of with abemaciclib, so even with prior CDK4/6 inhibitor, there is still a longer PFS of 9.1 versus 3.7 months for these patients. And then when we break it down based on other secondary endpoints of overall response, we see that overall response, again, for the imlunestrant and abemaciclib arm seems to be the highest in terms of those with ESR1 mutations for imlunestrant and abemaciclib, and we still see an overall response benefit for imlunestrant alone only in the group with ESR1 mutations. Overall survival analyses are still immature. And then in terms of safety and tolerability, I think this is pretty expected in terms of what we know of oral SERDs, very generally safe safety profile. And then in terms of AEs with a combination of abemaciclib, again, nothing that is different from what we know about CDK4/6 inhibitors in terms of diarrhea and cytopenias. So now when we think about the results of the study in comparison to our prior data in the setting of for other SERDs and SERMs, results are pretty concordant in terms that each have shown improvement in progression-free survival for tumors that harbor the ESR1 mutation, whereas ESR1 wild type seem to have no difference. And so in terms of key takeaways, I think what's novel in this study is that it's showing that this is the first oral SERD study that has shown benefit regardless of an ESR1 mutation due to the combination with abemaciclib. However, I think the important things to be aware of this study is the standard of care arm design, which was just fulvestrant or exemestane. And so it doesn't show us how the regimen would compare to something like fulvestrant with abema or fulvestrant with a CDK or with the PIK3CA targeted therapy. Additionally, because only 60% of this patient population received prior CDK4/6, the graph to the right, this was what was presented in the discussion section or following the abstract presentation, and show that the PFS study of the studies with prior CDK4/6 inhibitors starting on the left with oral SERDs, followed by AKT inhibitors, and second line with CDK4/6 inhibitors, they all show that there is a modest PFS improvement in comparison to the EMBER results with oral SERD and abemaciclib. So I think that in terms of what we really will have to kind of see how this ends up getting approved in terms of if it will be in the caveat of just ESR1 mutations as monotherapy or for that combination. And then again, this was also presented as in terms of from the discussion section about how this could potentially fit in if it does get approved. So potentially in the second line setting after progression on AI versus fulvestrant with a CDK4/6, both either following adjuvant or metastatic treatments, and can be used regardless of the genomic profile, but with a variety of other options to choose from. And so the next study that I'll be talking about was the PADMA study. So this is a phase 4 trial comparing first-line endocrine therapy plus palbociclib versus standard monochemotherapy for women with high risk HER2-negative HR positive metastatic breast cancer who have an indication for chemo. So I think the rationale behind this study, similar to that of Right Choice and Young Pearl, trying to look at these patients who have high risk metastatic breast cancer and looking at if there is truly a benefit of using chemotherapy in the first line setting. And so how the study design is they were really allowing physicians to choose high risk patients who meet this indication for monochemotherapy. So that is a key difference between this and the Right Choice trial. And I think it's also similar in that it's for patients who we would consider to have visceral crisis. And then another important aspect of this trial is they did allow patients to have endocrine therapy maintenance. So in terms of how they were randomized, they had to have this indication for monochemotherapy. They were either randomized to receive palbo with endocrine therapy or chemotherapy, monochemotherapy physician's choice, with or without an endocrine therapy maintenance. And so in terms of baseline characteristics, about 40% of them had liver metastases, 30% had were considered endocrine resistance, which was defined as relapse within 12 months of the end of their adjuvant endocrine therapy. And about a third of the patients had de novo metastatic disease. And then in terms of study treatment, so for the arm of physician's choice chemotherapy, majority of patients, as I think is kind of standard of practice, has received capecitabine followed by Taxol. And then only not even a quarter, 22% received endocrine therapy maintenance following chemotherapy. And then in terms of types of endocrine therapy that they received, I think kind of is in consensus with what we use in the real world of aromatase inhibitors. So I think I'm missing a slide here. The primary endpoint, which was treatment to failure. So I apologize for that, but essentially this study showed that there was a significant improvement of time to treatment failure in comparison of chemotherapy versus, of palbociclib with endocrine therapy in comparison to chemotherapy. These were the graphs for the secondary endpoints, which were progression-free survival. So this again was showing what similar results from the primary endpoint. There was a difference of 19 versus 8 months for progression-free survival. And overall survival between the two arms was numerically longer for palbo with endocrine therapy, but it was not statistically significant. And so I think in terms of what the results of this study tell us, it's consistent with what we see from results from Right Choice and Young Pearl, that CDK4/6 with endocrine therapy is still should be used in the first line setting, regardless of what we would consider maybe visceral crisis or people who have high risk disease. And we see that there is improved progression-free survival benefit. I think when we also think about this in terms of real world data, there was overall survival real world data that was presented at San Antonio, looking at OS in comparison to the 3 CDK4/6 inhibitors that are currently available, and showed that the survival rates were identical among the three. So I think, and then when we think about other trials that we're seeing, including the Patina trial, and then we also have the current indication of Anavo as well that's using Palbo. It also shows us that Palbo is still a reasonable option for these patients. And so, I think that it's something that in terms of what we can use currently, it shouldn't be something that we kind of miss out on in that. All right, and then I think I have a few minutes to quickly go over some results from Margo. Margo was a TBCRC study that was open here at our site that Rachel was the PI for. And this was a neoadjuvant phase 2 study for patients with stage 2 to stage 3 HER2 positive breast cancer that were randomized to receive neoadjuvant THP versus Taxol with margetuximab and pertuzumab. Any hormone receptor status was allowed on trial. They had to be treatment naive. And an important aspect of the trial is they had to have the CD16 genotype being FF or FV. And this is going based off of the implications of whether margetuximab has improved binding for the CD16 FF and FV alleles. And so primary outcome for the study was the pathologic complete response rates after receiving neoadjuvant treatment. And so in terms of their primary outcomes, they did see a numerical improvement in PAT-CR, but it was not statistically significant. There was a slightly higher PAT-CR in the HR positive subgroup with the margetuximab group of 54 versus 34%. However, there was a lower PAT-CR that they saw for the subgroup of that was HR positive, HER2 positive. They did not end up seeing any differences between the CD16 FF and FV genotypes. But overall, in terms of adverse events, slightly similar, were similar except for slightly more infusion reactions with the margetuximab combination. So that's all I have. I realize I didn't leave time for questions for each trial, but
Thanks, Vidya. Great job. Sorry, I was off camera a little bit. I'm in clinic here. So I think we've got just a couple minutes for any questions.
I love the Padma data, and I love the way that they sort of nicely combine with the right choice data, as well as some of the data from like Young Pearl and Pearl. I'm pretty convinced that even in the setting of visceral symptomatic disease, so-called visceral crisis, that this CDK4/6 inhibitor should be the regimen utilized. In true visceral crisis, the patient's so sick, it's hard to even give them chemo sometimes. Their LFTs are abnormal, but it's a pretty rare thing to see. And so just seeing if, just litmus testing that, anyone disagree, or do you all agree that really the use of chemo is kind of fallen by the wayside now, and these data are really encouraging of that, at least in the front line?
I think we've got an accumulation of data that certainly supports it. I mean, you can always imagine a circumstance with someone with a gut full of disease who's having trouble with orals where you might have to think about something different, but that's also quite uncommon.
Or you can think about the patient who has some, an ER negative biopsy in the setting of having prior ER positive disease, then I might consider, chemotherapy because she's no longer ER positive. But no, I think there's an overwhelming amount of data that suggests that this is the right first choice.
I think the
think
Ember
the
data are very complicated, and I'm not super convinced. I don't know
Yeah,
about
I mean, I think there were so many comparisons, it's hard to know for sure that everything that's real. And I'm really curious to know how they're approaching this with regulatory authorities and what they're trying to try to go after, because it feels hard to get all of these indications. So, yeah, but thank you for doing a really great job of clearly presenting that video, because I had the same. There's kind of a lot of different comparisons there with all the different choices. So. I guess before we go, just as also a little bit of an advertisement and announcement, and I think Gina mentioned this in the chat, we do have just recently opened the Elevate trial, which is looking at a number of different combinations with OSS strand. And I think there's somewhat of a wait list, but we're hopeful to have some of these different cohorts D and E open at our site and at Northwest as well. And I don't think prior chemo is permitted on that one. I think they can have prior endocrine, but not chemo, if I recall correctly. Well, perhaps on that note, I'll say thanks, everyone. Really fantastic presentations. Thank you all. You guys are so great. And we will hope everyone has a good rest of day. We'll look over the docket and see what else we would like to present for February at 10. Thank you so much to our presenters. Take care.